as well?
Yeah, we hear you.
Okay, great.
All right, so we have the pleasure of having Dr. Abdul Kouanda now. We all know him very well, as we know he's one of the advanced endoscopists here who specializes in taking care of patients with cancerous and non-cancerous diseases, mostly of the biliary tract and the gallbladder and pancreas. And he uses a lot of advanced techniques, including ERCP, EUS, and ESD in order to treat a lot of these conditions. And we'll hear a little bit about kind of the state of the art of that today. He also really works kind of in multidisciplinary teams with other GIs, with the surgeons, as we know, a lot with the liver transplant team, oncologists and radiologists to really provide kind of top-notch care to these like very complex patients. His research interests include patient outcomes, safety, and novel therapeutic approaches in endoscopy. He's also interested in endoscopic treatments for weight loss and GERD. He earned his medical degree from the Renaissance School of Medicine in Stony Brook. And then at UCSF here, he did his residency in internal medicine, fellowship in gastroenterology, and then the advanced fellowship in interventional endoscopy. He's also the director of the Advanced Endoscopy Fellowship here. And I think in general, just an amazing educator that all the fellows really enjoy working with. I've worked with him only a few times, but it's always been kind of a pleasure. I feel like I always learn something new. So very excited to hear this talk, and thank you for being here.
All right, thank you for that introduction, Alejandro. So the title of my talk is Swallowing the Future, Endoscopic Innovations in Managing Achalasia, Gastroparesis, and GERD. So today I'll be talking to you about essentially 3 topics that are near and dear to me. Each of these topics could be an entire talk of their own, but I'll try my best to fit it into this hour. So we'll be discussing achalasia and POEM, gastroparesis and GPOEM, GERD, and TIP. The objectives are to understand endoscopic techniques, review selection criteria, and discuss outcomes and complications. So let's get started with achalasia. So as we all know, achalasia is due to impaired LES relaxation of swallowing and aperistalsis of the smooth muscle. The pathophysiology is related to essentially loss of ganglion cells in myenteric plexus. Why these ganglion cells die off is not entirely clear. There's some theories related to potential autoimmune infections triggered by latent viruses such as herpes, but it's still an area that we don't entirely understand. Patients typically present with dysphagia, regurgitation, chest pain tends to be more common in younger patients. Patients can have hiccups, halitosis, weight loss, aspiration pneumonia. On average, about 4.7 years from the onset of symptoms to diagnosis. 10% of patients may have bronchopulmonary complications, mostly aspiration pneumonia, but there's some rare reports of tracheal compression from megaesophagus. The diagnosis is based on a number of tests, including endoscopy, esophagram, manometry, and in borderline cases, endoflip can be helpful in establishing the diagnosis. So I'm just gonna show a video. So this is the endoscopic video of a patient with achalasia. Typically, the esophagus is very dilated. There are a lot of secretions, as you can see here, that pool. So the fellow is here trying to suction up all those secretions. It's pooling of fluids. There could be mucosal changes like erythema, ulceration. Sometimes we see white plaques from Canada. The LES, which you'll see in a second, does not really open spontaneously. Gonna have to like push scope a bit hard with some gentle pressure, and then you pop through. This is and in really severe cases, like in this patient, this was a patient I did a couple of months ago who basically had fluid column and fluid all the way to the proximal esophagus. So on esophagram, the classic sort of finding is the birds beaking. This is another patient that I saw who had a really beautiful image that I'm showing here, and he had all the classic esophagram findings: the bird's beak, the dilated esophagus, delayed passage of contrast. You really don't even see any contrast in the stomach at all. Oftentimes the esophagus can be very tortuous with a sigmoid-like shape. So that's what we expect to see in the esophagram. And on a manometry, manometry is essentially essential for the diagnosis, and we usually look for elevated IRP with failed peristalsis or spasms. So manometry helps us differentiate the types of achalasia, 1, 2, and 3, and EGJ outflow obstruction. So these are some manometric images, and you can see this is type 1 achalasia, where there's basically no peristalsis, type 2 with panesophageal pressurization, and type 3 with spasm. Most of the patients I see are go through Priya Tipaya, who does an amazing job of evaluating them and establishing the diagnosis. So we're very fortunate to have a very outstanding motility specialist. So shout out to Priya. It's also good to know that not everybody with manometric findings consistent with achalasia actually has achalasia. So this is a patient I saw with locally invasive pancreatic cancer who developed dysphagia, underwent an endoscopy, which only showed a hypertonic LES, and then underwent mano, which showed this, consistent with type 2 achalasia. I reviewed his CT, and you can see here, pancreatic tumor invading into the stomach, the GE junction. You can see air in the esophagus, and then the esophagus is just sort of engulfed in this tumor en route to the stomach. So this is actually a case of pseudoachalasia. So this patient did not need POEM, and they actually needed an esophageal stent, which I ended up placing. You can see a very tight waist here at the point of obstruction. So I'm going to go a little bit over achalasia, the history of achalasia and the treatment of achalasia. So the disease was first described in the late 1600s. In 1913, Ernest Heller performed the first helomyotomy. In the 1950s, we saw pneumatic dilation take off, which was very effective treatment for achalasia, but patients often required repeated dilations. In the 80s, we saw laparoscopic helomyotomy. In the late 80s, Botox came into play and also was effective, but patients lose effect over time, and there's often tachyphylaxis. In 2008, the first POEM procedure was performed in a human by Dr. Haruhiro Inoue in Japan. And since then, POEM has essentially taken off globally and is now considered first-line treatment for achalasia. In 2014, there was a pivotal study comparing POEM with laparoscopic helomyotomy, which showed comparable effectiveness. POEM was non-inferior to helomyotomy, and this really invigorated the use of POEM for treating patients with achalasia. So before POEM was performed in humans, it was actually performed in pigs first. So the idea of submucosal endoscopy and myotomy was first explored in 2007 by P.J. Pariska. He basically theorized that that he can perform a myotomy while working in the submucosal space. And he performed 5-centimeter circular myotomy on 4 pigs. All 4 pigs had their LES pressures dropped, and on autopsy, there were no complications. In this paper that he published, he wrote, "The submucosal space is a novel and potentially important field of operation for endoscopic procedures." And this is clearly a huge understatement in hindsight, considering where the field of third space endoscopy has gone since then. So in 2010, this paper was published. This was the first sort of series on humans. So Inoue did the first procedure in 2008, and then in 2010, he published his experience with 17 patients who underwent a POEM procedure. All the dysphagia scores on average improved from about 10 to 1.3. That's the Eckhart score. All patients had reduced LES pressures, and there were no serious complications. So moving on in 2014, as more people were performing home for achalasia. So this was a ASG white paper that came out, which looked at 14 studies at that time, from 2010 to 2013, on 804 patients. So overall, the therapeutic success was very high, over 80%, and in some series, 90 to 100%. And all there were dramatic improvements in Eckhart scores and LES pressures overall. So in terms of long-term outcomes, so this was the first study to look at that, published in GIE back in 2021. They looked at 610 patients from 2009 to 2019, and they looked at clinical success, over 90% during that period. At 10 years, there was no aborted poem. The median operation time was 54 minutes. Inadvertent mucosotomies in about 10.5% of patients, adverse events in 3.4% of patients. And notably, there are no adverse events that led to death, surgery, interventional radiology, procedures, or altered functional status. So, this study really showed that over the course of 10 years, home was very durable, safe option. I'll talk more about reflux later, but about 20.5% of patients had reflux symptoms more than once a week after 10 years. This is a Kaplan-Meier curve, which shows the efficacy of home after 10 years of follow-up. So I'm going to talk a little bit about the technical aspects of home for achalasia. The procedure is essentially divided into 4 phases. So the phases are basically mucosal incision and entry into the submucosal space, dissection of the submucosal space into the cardia, myotomy of the inner circular or outer longitudinal muscles, and closure. So this is I'm going to just show a video of one of my patients. So I performed the procedure using a hybrid I-type knife. I like it because you can inject and cut simultaneously without exchanging devices. So I usually make about a 1 to 1.5 centimeter incision after a submucosal bleb. I use a methylene blue, which essentially colors the submucosal fibers, which you can see here, allows us to visualize the submucosal fibers. The mucosotomy is then dissected until I could see the muscle layer and enter the tunnel. So this is a video showing the tunnel. So at 12 o'clock is mucosa, at 6 o'clock is muscle, and in between is the submucosal space, which is colored blue by the methylene blue. So the hybrid knife is basically used to dissect the submucosal space from the point of entry down to the cardia. Occasionally we run into bleeding vessels, which can be treated with the knife or with a Kouanda grasper, as you see over here. So once I get into the cardia, I come out and go back into the stomach, and you can see basically a bleb in the cardia, which confirms that we've made our way across the lower esophageal center. This video shows the myotomy. So at 6 o'clock, you can see the muscle layer. The inner circular muscle layer is dissected first, and then the outer longitudinal layer. So the hybrid knife is essentially used to incrementally cut these fibers, which then allows the muscle to splay open, ultimately leading to reduced LES pressures. We'll talk a little bit more about the types of an approach to myotomy. I've basically done a myotomy of the entire tunnel here. You can see this is a full thickness myotomy. You can see the adventitia layer. The scope goes back into the stomach. You can see this is the same patient. The LES pressure is significantly reduced. It's much easier to go to the lower esophageal sphincter. And finally, closure. I couldn't really find a great video of this. It's not my best work. There's this little awkward clip here. Nonetheless, the mucosal incision was closed properly. This scope is used to essentially make sure there are no inadvertent mucosotomies at this point. So I'm advancing the scope to make sure of that. You can see the LES still looks nice and open post myotomy. And at this point, the procedure is essentially done. So I usually perform endoflip before and after the procedure. For those who don't know, endoflip is a catheter-based instrument with an attached air-filled balloon, which is surrounded by a series of impedance planimetry electrodes. The catheter is advanced through the mouth across the LES. The balloon is distended, and real-time measurements of the distensibility index, diameter, and cross-sectional area of the sphincter are performed. It's used during POEM to ensure adequate myotomy. We usually try to target a distensibility index greater than 3. DI less than 2.8 is associated with worse outcomes. So this is the same patient. You can see this is the pre-POEM endoflip. The distensibility index is very low, 0.4. You can see the red high pressure zone at the LES. So this DI is sort of similar to having a very elevated IRP. They go in opposite directions. This is post myotomy. You can see the high pressure zone has been eliminated. The sensibility index is now 6 point, greater than 6. So we've achieved an adequate myotomy. So there are a number of technical considerations when performing POEM. The first is whether to do an anterior or posterior approach. We don't really do left or right, since it's technically easier to do anterior or posterior. The anterior approach is theorized to preserve the posterior gastric slim fibers, and this is postulated to possibly decrease post-POEM reflux. That's unsubstantiated. And the posterior approach starts to decrease bleeding from branches of the left gastric artery located in the anterior submucosal space. So there's a randomized trial of 150 patients looking at anterior versus posterior, and basically there was no difference in clinical success, esophageal acid exposure, GERD quality of life scores. Personally, I perform a posterior approach. I find it easier. And, on the anterior side, you have your great vessels, the cardiac chambers, and it's my preference to just generally avoid that area. Inner circular versus full thickness myotomy is a topic of debate. One retrospective study of 103 patients who had full thickness versus 131 that had a selective circular myotomy. The procedure was overall shorter with full thickness myotomy, which makes sense because it takes a lot more precision to carefully dissect out the inner circular layer. There's no difference in clinical success, adverse events, or GERD, whether you did inner circular or full thickness myotomy. So as a result of that, I generally do full thickness myotomy out front. The other thing that I've learned over time is even when I've done a selective circular myotomy, the outer longitudinal layer is generally a very thin layer of muscle, and the inner circular is generally very, very thick in achalasia patients. So that thin layer of muscle, even when a myotomy is not performed, it tends to splay open regardless of whether you preserve it or not. In terms of myotomy length, so the standard myotomy length is about 10 to 12 centimeters above the GE junction. A short myotomy would be about 4 to 6 centimeters above the GE junction. So in this meta-analysis of 521 patients, there was no clinical success, no difference in clinical success or adverse events, and short myotomy was associated with shorter procedure time, which makes intuitive sense. So I generally perform a short myotomy. In terms of closure, clips are faster and cheaper, so I usually use clips. There is a role for suturing. I've had one patient who had a extremely thick mucosal epithelium and muscularis mucosa that was very difficult to bring together with clips. I actually had to go back in because the patient essentially had wound dehiscence because the clips wouldn't close the defect properly. So in that patient, I removed the clips and performed endoscopic suturing, which led to a durable closure. So, I'm going to talk a little bit about other how POEM compares to pneumatic dilation and laparoscopic helomyotomy. So first, pneumatic dilation. This was a randomized trial published in JAMA back in 2019. There were 67 patients in the POEM group and 66 in the pneumatic dilation group with 2 years of follow-up. Clinical success was 92% in the POEM group and 54% in the pneumatic dilation group. There was higher GERD in the POEM group, which is not too surprising. There were 2 serious adverse events in the pneumatic dilation group versus 0 in the POEM group. Pneumatic dilation it's a very aggressive dilation, uncontrolled. It's not, it's uncontrolled at the G junction, and there's a very high risk of perforation that is essentially not related to expertise. It's sort of a random how the G junction will respond to the dilation. So this study essentially shows a superiority of POEM over pneumatic dilation. This was confirmed in a meta-analysis of over 6,000 patients, which showed at 36, over 6,000 patients, which showed basically great clinical success with with POEM as compared to pneumatic dilation. Again, there were slightly higher rates of GERD with POEM. There was no difference in the bleeding or perforation risk. So a randomized trial was published in the New England Journal in 2019, comparing laparoscopic helomyotomy to POEM. There were 221 patients that were enrolled, and patients who had the helomyotomy also got a door fundoplication. They were followed for 2 years. At 2 years, POEM was non-inferior to laparoscopic helomyotomy with door fundoplication, 83% versus 81.7% success rate. GERD was more common in POEM patients, but it was still very common in patients who had a laparoscopic helomyotomy with door fundoplication, 29%. There's always the question of POEM in previously treated patients. Patient had a prior laparoscopic helomyotomy. They have recurrent dysphagia, and there's evidence of recurrent recurrent achalasia. What do we do now? This was an RCT of POEM versus pneumatic dilation. I'm sorry, yes. So POEM versus pneumatic dilation in patients who were previously treated with laparoscopic helomyotomy, and clinical success was higher with POEM in this group than pneumatic dilation, to 62% in POEM patients versus 26% in pneumatic dilation group. This was a non-comparative meta-analysis, so they just looked at patients who had prior laparoscopic helomyotomy and then underwent POEM. The clinical success in this group was 99.3%. I'm sorry, the technical success was 99.3%, and the clinical success was 90%. So very, very effective for previously treated patients. So one of the complications of achalasia is epiphrenic diverticulum, which is also known as a ulcered diverticulum, usually caused by increased pressure in the esophagus. Um, this is traditionally treated with a surgical diverticulectomy, but diverticular or oral endoscopic myotomy has emerged as an alternative option. So this was a patient that I saw with type 2 achalasia. They had this very large epiphrenic diverticulum. I initially did a palm procedure. They had some improvement, but they continued to have symptoms and we postulated probably related to this diverticulum here. So the idea is to essentially reduce the diverticular, septum. By myotomizing the diverticular septum, the separation between the esophageal lumen and the diverticular lumen is reduced, and that decreases stasis of fluid and liquid in the diverticulum. So after several months, the patient was brought back for diverticular septotomy. So this is the muscle of the diverticular septum in this, which has been dissected out in the submucosal space. And this is after I performed the myotomy of that diverticular septum. You can see the adventitious layer below. And this is a esophagram after the diverticular septotomy, which showed, there's still some pooling of liquid, but that sort of separation is reduced. And you can see that there's improved flow of contrast into the stomach compared to prior. I'm going to talk a bit about adverse events related to palm. So the biggest is GERD, which I talked about a little bit already. So GERD is essentially the Achilles heel of palm. This was a meta-analysis of 18 studies, which looked at risk factors for GERD. They looked at many different variables, demographics, the type of myotomy, approach to myotomy, the length of myotomy, whether they've been treated before, etc. And they essentially concluded that there are no modifiable risk factors to reduce GERD after palm. And not shown here, but there was a randomized trial published in the last year, which looked at patients who underwent myotomy with myotomy of the gastric sling fibers versus just a traditional myotomy while sparing the gastric sling fibers. And the incidence of GERD didn't differ whether you performed myotomy of the gastric sling fibers or not. So this remains an ongoing issue with palm. Fortunately, I haven't had any patients who had GERD that was so severe that they required anti-reflux procedure. Although it's common, the vast majority are mild and controlled with PPI or lifestyle modifications. Blown out myotomy is another complication of palm. It's a distal esophageal pseudodiverticulum, essentially caused by esophageal wall stretch in the setting of persistent high intrabolus pressures, despite palm, with a weakened esophageal wall due to the absence of the muscle layer after palm. So blown out myotomy can contribute to persistent GERD after palm. It's associated with both palm and laparoscopic myotomy, and it's actually much more common with laparoscopic myotomy than with palm. Patients with type 3 achalasia are at more increased risk than the other types of achalasia. And there's a thought that a shorter myotomy and avoiding an anti-reflux procedure at the time of myotomy can reduce the risk of blown out myotomy. There are a number of insufflation-related adverse events. Pneumomediastinum, pneumoperitoneum, or subcutaneous emphysema are expected post-procedural findings since we're in the submucosal space. CO2 is used, so there is some, CO2 that escapes into these spaces. it's generally inconsequential and there's nothing to do about it. More severe complications like pericardial effusion, pneumopericardium, hemothorax, hematoma. These are extremely uncommon, and fortunately, we have not had to deal with that here at UCSF. One thing I'm gonna make a slide on is post-home pain. This is an issue for some patients. It's a topic of, although research is not really clear. There are patients who wake up, I would say probably more than half patients wake up after the procedure. They have essentially zero discomfort. They go home the following day. And there are some patients who wake up in severe pain and it's not clear they had the exact same procedure, the exact same steps. It generally gets better after a couple of days, but that is something I always counsel patients on, that they could have chest pain after the procedure. Afterwards, generally NPO, they get a esophagram in the morning to make sure that there's no leak, and then they're discharged. Follow up with both Kapalia. In terms of long-term follow-up, there's a very small risk of squamous cell cancer, estimated about 1.3% in this study of almost 7,500 patients. Whether to perform an endoscopy is a topic of debate. One study showed that essentially you needed to do 400 endoscopies to detect colon cancer. Regardless, many experts recommend surveillance every 3 years, about 10 to 15 years after the diagnosis. Here at UCSF, we do survey patients for SCC. And there's also a risk of recurrent achalasia over the long term, about 9 to 10% risk, and this can be treated with either a repeated POEM or Heller myotomy. So, it's the first third of my presentation. POEM is a safe and effective first-line treatment option for achalasia. It's effective for both treatment-naive and previously treated patients, and GERD remains the Achilles heel of POEM with no effective preventative strategies to date. So I'm going to talk a little bit about gastroparesis, and try to avoid being too redundant from Connie's talk. So as she mentioned, endoscopic treatment is really for refractory gastroparesis despite maximal medical therapy. She talked about Botox, how those two RCTs did not show any benefit. However, we still do it. There is a population of patients that seem to respond, and she already talked to you about that pyloric desensibility study. Pyloric stenting has also been shown to be effective, but this is not really something we do anymore. There's a very high migration risk with the stent, even when it's sutured in place. Laparoscopic pyloroplasty is the surgical equivalent of a GPOEM, and it is also effective and has been shown to improve gastric emptying and GCSI. Gastric electrical stimulation is also an option. There's this device called Entera, which is surgically implanted. It's approved as a humanitarian exception device for diabetic and idiopathic gastroparesis. There's one RCT of 172 patients who all had the device, and they were essentially randomized to the device in the on or off position. And the incidence of vomiting was reduced when the device was on as compared to off. It hasn't been shown to work well for patients with pain or bloating predominant symptoms. And then there's GPOEM, first performed in 2013 in humans, I believe by Bonk Shab over at Hopkins. The pathophysiology of gastroparesis is complex and not fully understood, but GPOEM is thought to treat the pylospasm component, which can coexist with delayed gastric emptying. The procedure is fairly analogous to esophageal POEM. A mucosal incision is created about 4 to 5 centimeters from the pylorus on the greater curve, though some providers do it on the lesser curve. A submucosal tunnel is then made and extended to the pyloric ring. And then a biotomy of the pyloric ring is performed, being careful not to breach the serosa lining. And then the mucosotomy is closed using clips or suturing. This is a photo from patient from a while back. You can see this sort of whitish muscle. This is the pyloric ring, and distal to the pyloric ring, you can see the submucosa of the duodenum. So once we get to this ring, we stop because the duodenum is very thin and you don't want to risk the perforation of the duodenum. So she talked a little bit about this AGA clinical practice update. GPOM is really reserved for patients with medically refractory gastroparesis. They need a positive gastrointestinal study. They need to have tried Reglan and dietary changes. There needs to be no evidence of mechanical gastric outlet obstruction. They need to have moderate to severe symptoms with a GCSI score of at least 2. Patients with nausea and vomiting predominant tend to do better. And prior therapies, patients who've had prior therapies are still candidates for GPOM, whether they've responded to them or not, including like gastric electrical stimulation, pyloric stent, Botox. All these patients can get GPOMs. I'm going to go a little bit quickly because I want to talk about TIFs. The adverse events are mild, usually normal pain is the most common, very rarely pneumoperitoneum, perforation, and bleeding. If there is pneumoperitoneum, needle decompression may be needed. This is one of the most impactful, I think, studies on GPOM. So this was a randomized sham controlled trial. So basically, there were 21 patients who were randomized to GPOM and 20 patients that were randomized to a sham endoscopy. And the study had to actually determine it early because the success rate was so much higher in the GPOM group than the sham endoscopy group. So 71% in GPOM versus 22% in sham. And 12 patients crossed over to GPOM from the sham group, with 9 of them achieving treatment success. There are 10 adverse events, 7 after GPOM and 3 in the sham group, all related to anesthesia. This is a meta-analysis published by a former interventional fellow, looking at 1-year outcomes of GPOM. He included 10 studies, 482 patients, and the pooled clinical success of 1 year was about 61%. A more recent meta-analysis of 20 studies and nearly 800 patients showed a 98% technical success rate. The mean GCSI score improved by 1.56 points. There was a 50% improvement in gastric retention and a 10.9% adverse events rates. These are some of the factors that predict response. So to GPOM, so having a higher baseline GCSI, pre-GPOM response to Botox is helpful, or stent, diabetic and post-surgical radiologies, lack of psychiatric diagnosis is huge. I treat these patients similar to esophageal POM. They get an upper GI series the following day to make sure that there's no leakage. Then a full liquid diet for the first 72 hours. Then they transition to a gastroparesis diet, BID PPI to prevent ulceration of the mucosotomy. And then they're followed up to try to essentially wean off the gastroparesis meds if possible. And then they get a gastroparesis study in about 6 months to reassess. The take homes here are gastroparesis is minimally invasive and somewhat effective. Studies seem to show improved symptoms. The most important thing by far is patient selection. That is absolutely the most critical part of this process. And even though there are some positive findings so far, long-term data is really needed to assess the durability and safety of GPOM. The number of other, third space procedures, which take on the POEM technique, including Zenker's diverticulotomies and submucosal tunnel endoscopic resection, which is a new technique for removing submucosal lesions of the GI tract, but I'm not going to get into that. Because I really want to talk about TIF, or transoral incisionless fundoplication. So this is essentially an endoscopic procedure, which is done under general anesthesia using this giant esophagus device. It's used to create full thickness serosa to serosa plication of the gastroesophageal junction, lengthening that flat bowel by about 3 centimeters and creating a 200 to 300 degree fundoplication. It's FDA approved in the United States for the TIF procedure. To understand why and how TIF is effective, we need to understand a little bit about the pathophysiology of GERD and the gastroesophageal flat bowel. So as we know, GERD occurs when reflux episodes result in symptoms and complications. And the pathophysiology of GERD has many components listed here. Decreased salivation, impaired esophageal acid clearance, transient lower esophageal sphincter relaxation is a big part. But the most important mechanism of GERD is likely, the deterioration of the anti-reflux barrier over time. So the components of the anti-reflux barrier are the right crura of the diaphragm, the gastroesophageal flat valve, and the lower esophageal sphincter. So the right crura of the diaphragm has essentially a pinching effect on the lower esophageal sphincter, and basically keeps the fundus in the cardia or the stomach below the diaphragm. And when it is compromised, the fundus in the cardia can migrate above the diaphragm, resulting in obliteration of the angle of His and the development of a hiatal hernia. The G-junction flat valve is that mucosal fold that we see when we retroflex in the body of the stomach and visualize the gastroesophageal junction. When it's normal, it's situated tightly around the scope, and it requires the crura and the angle of His to function properly. And then there's the lower esophageal sphincter, which provides the tone that prevents reflux into the esophagus. So over time, in some patients, this sort of anti-reflux barrier can deteriorate. If the crura weakens, the angle of His goes from this acute to obtuse angle, the flat valve opens up, and over time, a hiatal hernia can result, leading to symptomatic reflux disease. So this, GERD really is very much an anatomical issue in the vast majority of patients. So when we assess this flat valve, the most, sort of the preferred measurement is the Hill grade. And this Hill grades 1 through 4. Hill grade 1 is essentially normal. Hill grade 2 is when you see a space between the scope and the valve that varies with respiration. Hill grade 3, you see a persistent opening that varies with respiration, but it's always an opening. And Hill grade 4 is essentially a gaping hole with a wide open hernia. So when we think about GERD treatment options, there are 3 main categories. So lifestyle changes, medical management, and anti-reflux surgery. The jump from medical management to anti-reflux surgery is a pretty big one, and many patients don't want surgery. And this essentially leaves a therapeutic gap in treatment. So TIF can fill that therapeutic gap that exists between PPIs and laparoscopic surgery. Sort of similar to what percutaneous coronary interventions have done in cardiac patients or arthroscopy has done in orthopedic patients. I'm gonna skip this slide, it's a bit technical. So I just want to show this video. So this is the esophagus device, which is used to perform TIP. This bending portion is called a tissue mold. The scope goes through the device, and the entire apparatus is advanced into the stomach. I usually dilate the hypopharyngeus with an 18 Savary before I pass this device. Once it's in the stomach, it's turned on itself. There's a device in it called a tissue retractor, which is used to essentially pull the gastroesophageal junction down into the space between the shaft of the device and the bending portion, which is the tissue mold. And pressure is applied at right and left. Torque is applied to give the effect of the fundoplication. And these H-shaped fasteners are deployed to create a serosa to serosa fusion. And this is essentially repeated along that gastroesophageal junction to create and lengthen this omega-shaped flap valve to reduce reflux. This is just a cartoon of the H-shaped fastener used to bring the two seroses together. Each cartridge that we use during the procedure has about 20 fasteners. Patients are admitted post-procedure, though many centers don't admit patients. They do simply can send them home the same day, but I prefer to admit them for observation. You know, patients are generally on a liquid diet for 2 weeks and a soft diet for about 4 weeks, and then diet is advanced slowly. It's important to control nausea, because retching can dislodge the fasteners. I also counsel patients to avoid heavy lifting for 6 weeks after the procedure, to limit it to about 25 pounds, and on follow-up, gradually wean off the PPIs. So who's a candidate for a TIF procedure? So these are patients with symptomatic chronic GERD who require and respond to pharmacological therapy. So these are patients on PPIs who have improved but persistent symptoms, or patients who have symptoms that are completely controlled with PPIs, but they have a desire to discontinue PPIs in the future. GERD should be confirmed either by the presence of esophagitis or pH testing, and manometry is generally required, especially if the patient has dysphagia. There are a number of contraindications, you know, including BMI greater than 35. These patients are candidates for room-wide gastric bypass, which is can control the reflux and the obesity. And patients with hyohemia greater than 2 centimeters are not candidates for TIF alone, but I'll talk a little bit about CTIF a little later on. Patients with severe esophageal mucosal disease, a lot of this is like pretty obvious, common sense. You know, if someone has a stricture, you can't pass the device, etc. So this is the Tempo trial that I just want to talk about here, published in 2015. This was a multi-center randomized trial of 63 patients who underwent either TIF or PPI, and they were followed for 6 months. At 6 months, troublesome regurgitation was eliminated in 97% of TIF patients versus 50% of PPI patients. 90% of TIF patients were off PPIs. 54% had normalized esophageal acid exposure after TIF, and extraesophageal symptoms were more reduced in TIF patients than the PPI groups. Notably, there was no de novo dysphagia, which is important when you think about laparoscopic fundoplication. So these charts show some of the differences between TIF and PPIs. TIF is in this sort of bluish color. And you can see elimination of these symptoms was much greater in TIF compared to PPI in all these symptoms except difficulty swallowing. There was no difference between TIF and PPI. And the patients who underwent TIF, 100% of them were on a PPI before TIF, and after TIF, only 90% were on a PPI. GERD quality of life scores decreased significantly over 6 months of follow-up. Interestingly, esophagitis healed more in the TIF group than in the PPI group, and heartburn was more improved in the TIF group than the PPI group in this study. That same year, another randomized trial came out in gastro. So this study it showed TIF to be effective, but not quite as dramatic as the Temple trial. So this is the RESPECT trial, and likely eliminated some bias because this was a sham control trial. So patient either underwent TIF plus placebo or sham EGD plus PPI. So the patients were blinded as to whether they got TIF or not. And at 6 months, patients underwent 48-hour esophageal pH study and EGD. And in this study, TIF eliminated troublesome regurgitation in more patients than PPI, so 7% versus 45% with a significant p-value. And more patients in the PPI group had no response compared to TIF, also statistically significant. And the overall time with esophageal pH, with improved esophageal pH, was also better with TIF, with significant p-value. So the authors concluded that TIF was effective for treatment of patients with GERD, especially those with persistent regurgitation, despite PPI, which makes a lot of sense because PPIs really treat acidity and not necessarily reflux, which can still be symptomatic. Non-acid reflux can still cause a lot of issues with patients. So this is a 5-year follow-up of the Temple trial. And at 5 years, there were no serious adverse events. There were 3 redo TIFs. More patients required PPI, so 34% were on daily PPI compared to 10% at 6 months. But that was still a significant improvement. And GERD quality of life was significantly improved at 5 years as well. This was a meta-analysis of TIF versus PPI, 18 studies, including 5 RCTs and nearly 1,000 patients. And the total satisfaction rate after TIF was nearly 70% at 6 months, and the incidence of serious adverse events was 2.5%. So you can see in this meta-analysis, the results favor TIF over PPIs in this patient population. So what about TIF versus surgery? So there are no head-to-head trials of laparoscopic fundoplication and hiatal hernia repair compared to TIF. But this was a network meta-analysis that was performed comparing using 7 trials and 1,128 patients. They looked at improved time with pH less than 4, the LES pressure, improved quality of life scores, and persistent esophagitis. So the patients who had Nissen fundoplication had improved time with pH less than 4. And this stands to reason because a Nissen is a much tighter wrap than a TIF procedure. In terms of the other factors, there's actually no significant difference between the LES pressure, the quality of life scores, and persistent esophagitis. It's interesting. I would have expected LES pressure to be higher in Nissen. It does seem to favor Nissen, but it's not statistically significant. Similarly, quality of life scores favor TIF. Though the bar crosses the line, so it's not statistically significant. And esophagitis seems to favor Nissen. Again, not statistically significant, but it does seem to favor Nissen. fundoplication. So what about CTIF? So CTIF is combined surgical hiatal hernia repair with endoscopic TIF. And this is taken off at centers across the country as an alternative to surgical hiatal hernia repair with Nissen fundoplication. So what is the argument for CTIF? So it's minimally invasive. There's a shorter recovery time. It has lower adverse event rates compared to the Nissen. CTIF preserves the blood supply given the need to divide the short gastrics during the Nissen fundoplication. CTIF spares the fundus, which preserves accommodation function. The fundus is used to wrap around the G junction in a Nissen fundoplication. And the CTIF is a less restrictive valve compared to Nissen, which has a very significantly high risk of gas bloat syndrome. So this was a retrospective study of 125 patients who underwent surgical hiatal hernia repair with TIF. So these are patients who had 2 to 5 centimeter hiatal hernias, so they were not candidates for TIF alone, versus hiatal hernia repair with laparoscopic Nissen fundoplication. And across the board, in terms of length of stay, 30-day readmissions, adverse events, and all of these favored TIF with significant p-values. So, we don't yet do CTIF here, UCSF offer TIF procedure. However, this is an area where we can collaborate with our surgical colleagues to offer CTIF to patients. We do need randomized trials to validate these findings comparing CTIF to Nissen fundoplication. So this is a patient that I did TIF on a while ago. So you can see this patient had Hill grade 2 hernia. You don't see it well here, but when the scope was sort of there for a little while blown there, you can see the space which varied with respiration. And you can see the TIF device through the G junction. And you can see this sort of flat valve elongating as the fasteners are being placed. And then this is the final result. You can see the lengthening of the gastroesophageal flat valve, tightening of that gastroesophageal sphincter. And this patient was able to wean off her PPIs over time. So in conclusion, TIF can fill the therapeutic gap that exists between PPIs and laparoscopic fundoplication. TIF accomplishes what other fundoplications do and does so with less side effects. And CTIF is a acceptable approach for GERD in patients with hiatal hernia and maybe the preferred approach for many patients. But this is something we will need to work with our surgical colleagues on. All right, that's all I got. It's a whirlwind tour. I'm happy to take any questions at this point.